Awesome. So we'll get started right now. Thank you all for being here to the Opioid Learning Institute DC Community of Practice. This is session 3 of the Community of Practice, and we have Dr. Desmarteau here, who is going to be presenting on opioid receptors, and then we'll go into a little discussion on that for the latter half of this hour. And just a quick intro, Dr. Desmarteau is a retired board-certified anesthesiologist. He worked locally with Kaiser, and feel free in the latter half of the discussion to ask questions. You can also pop some questions into the chat, and any questions that Dr. Desmarteau doesn't know the answer exactly to, he will be happy to get back to you all on that at a later time. So with that, Dr. Desmarteau, thank you so much for taking the time to do this, and I'll turn it over to you.
Okay, thank you very much. As Henry mentioned, I'm a retired board-certified anesthesiologist. And before I retired, I was the director of outpatient surgery for Kaiser Permanente here locally. And I think that's enough of my background. So I'm going to start with a very short history of opioids. And then we'll move on to the receptors. Then we'll talk about buprenorphine, methadone, and naloxone. We'll talk about cocaine, tolerance, and what's the future? Where can we go with this, with stuff? And our learning objectives. So I'm going to describe the opioid receptor system and its importance in general, and as it relates to opioid use disorder. Appreciate how genetic mutations possibly makes someone more susceptible to opioid use disorder. Describe the importance of opioid receptor binding and the relation with buprenorphine, methadone, and naloxone. Understand how cocaine's receptor binding can lead to its abuse and other problems with cocaine, and discuss ongoing receptor research into finding analgesics that don't have the serious side effects of our current crop of opioids, with the obvious two that affect the community that you deal with, which is respiratory depression and abuse potential. So here's a bit of a history. And I'm not going to read everything on, there's 2 slides here, but just to go over a couple of things. The poppy, the opium poppy, has been cultivated since at least 3000 BCE. By the way, poppies that grow that you'll see in gardens over here are not the poppy from which opium can be derived. Those plants are illegal here in the United States. Coca leaves, from which cocaine was derived, at least 1000 BCE. Morphine, which is the patriarch of the opioid family, was isolated in 1803. Cocaine, 1832. The hypodermic needle, 1853. So as you can see, none of this is exactly new. Now, I did decide to include a few things from anesthesia. Laudanum, which, by the way, is, believe it or not, is still sold, tincture of opium, began around the 16th century. Ether was first used in 1842 on March the 30th, which every year is Doctor's Day. And nitrous oxide was in 1844. So then we move on to more modern things. We get heroin, 1898, oxycodone, 1916, fentanyl, 1959, naloxone, 1961, buprenorphine, 1965, carfentanil, 1974, and the endorphins discovered a year later. One thing I'd like to mention from anesthesia was when I was an anesthesia resident starting in 1981, the fentanyl revolutionized open heart surgery because we were able to take people that previously couldn't fix their hearts, give them high dose fentanyl anesthetic, and they would survive the operation. Okay, so here's a classification of opioids by how they're made. The naturally occurring are morphine, codeine, thebaine, papaverine. The semi-synthetics are not completely laboratory made. They have a relation to the naturally occurring, and you can see the ones here. Heroin, dilaudid, hydromorphone, buprenorphine, and oxycodone, also sold as OxyContin. And then the completely synthetic includes meperidine, which is Demerol, fentanyl, methadone, and carfentanil. And also notice on this list is low fentanyl. And everyone who works in the field of addiction or has to treat these patients should thank their lucky stars that low fentanyl has not reared its head in the abuse scene because it is more potent than carfentanil. All of these bind, at least to some extent, to the mu receptor, which we're going to get into in a moment. So here are the receptors. So far, 17 opioid receptors have been identified, but the ones I'm going to talk about today are the mu receptor, and that was named after morphine, which is the classical ligand. Ligand just means things that bind to the receptor. So if you ever hear that word, that's what it means. The Kappa was named after catazocine, which was the very first ligand. And then the delta one was named after the vas deferens. Well, if you don't know what that is in anatomy, that is the tube that carries sperm from the testicle. And it was first found in mice. And then the last one, which was discovered only in 1994, is the nociceptin opioid peptide receptor. And that one is very interesting, and I'm going to talk about that right towards the end. Now, all of these are G protein coupled receptors, GPCRs, and they are integral membrane proteins that are used by the cells to convert a signal that arrives on the outside of the cell to a response that comes from the inside of the cell. And almost all the receptors in the spinal cord and the brain are GPCRs, not just the opioids. Okay, so as research has gone on over the years, we've found out that the 4 receptors that I'm talking about today, they have internal, what are known as endogenous ligands. So for the mu, we have beta endorphin, endomorphin 1 and 2. For kappa, we have dynorphin A and B. For the delta, met and lu and keflins. And for nociceptin, the nociceptin opioid peptide, there's the nociceptin/orphanin FQ. Now, the point of this is that the people who become addicted to opioids, it's not like these things are unknown in a sense to the body. And part of the response that the people have from the receptor binding is somewhat based on these endogenous opioids. All right, now here's a table which actually looks complicated, but isn't. You can think of it this way. Almost all of the opioids are agonists at the mu, kappa, and delta receptors and have no activity at the NOP. Buprenorphine is kind of the odd drug or the odd person out in that it is a partial agonist, meaning stimulant of the mu receptor, but it's antagonist at kappa and antagonist at delta. Naloxone, on the other hand, which I'm sure you're all familiar with, is antagonist at all three. And then I did add naltrexone because it's a bit of a weird one too. It's antagonist at all three, but it's also a weak agonist. Okay. So the opioid system regulates a diverse range of physiological systems, which includes how you sense pain, whether that pain sensing gives you an emotional problem, and obviously respiration, reward and euphoria, even immune function and the response to stress. All right, so let's go on to the mu receptor. It's the classical one typified by the action of morphine. And it's found in both the central and peripheral nervous systems and even in other tissues like the GI tract. There are three subtypes, mu1, 2, and 3. And out of all of the 17 receptors, opioid receptors that have been discovered so far, the mu1 is the most important and is the most understood. As I've mentioned, it's a G protein coupled receptor, and the activation has quite a few responses. So we know about analgesia, sedation and euphoria, of course, nausea and vomiting, respiratory depression. Meiosis is the medical term for a constricted pupil, constipation, urinary retention, tolerance, and physical dependence. So the ones that I've highlighted in bold are the ones that are, in a sense, most applicable to addiction medicine, although, nausea and vomiting, constipation, those also come into play. Okay, now, this is just to show you in a sense, how complicated this whole system is. But in short, the way the agonists that stimulate the mu receptor work is they block the inflow of calcium. You can see Ca2 plus, the inward arrow, that the agonist is binding to the receptor on the cell wall, and it blocks the outflow of potassium. The end result is that the cell becomes hyperpolarized, and because it's hyperpolarized, pain neurotransmitters are not released. So that's how it works for pain relief. Now, I am not a neuroanesthesiologist, although that was one of my interests, but I didn't end up going down that road, and I'm not a neurologist, so I don't pretend that I'm going to go over this entire slide. But the point of this is just to show, once again, how complicated the system is. In some parts of the central nervous system, the stimulation of the mu receptor leads to activation. In other parts, it leads to inhibition. And it's the balance of all of these things, when you put them all together, that leads to the end effect. Now, just to show you how we have progressed in our understanding of this system, is that this is a representation of the crystalline structure. Proteins have crystalline structure. And so they used X-ray crystallography, And they've been able to actually delineate the structure of the receptor. And in this particular case, they're showing how fentanyl actually binds in the receptor. They have been able to demonstrate this to a level of detail at a molecular level, which is, I find, intriguing and, well, quite exciting. Okay, so because they've been able to do this work, the researchers have found out that in some people, we'll get onto this more in a minute, there is what is known as a single nucleotide polymorphism. And there are, we'll abbreviate this as SNP, so I don't have to say this repeatedly, but SNPs are much more common than we ever thought. And they are involved in all kinds of things, a lot in cancer research, infectious disease, and opioids. Okay, so there is a gene, the OPRM1 gene, that codes for the mu receptor. And in some people, an SNP is created by an adenine, which normally binds to thiamine, being bound to guanine in a person's DNA. Okay, so it's a mutation. How it came to be, we don't know. But it does have a distribution based on ethnicity. It's about 2% in Afro-Americans, African-Americans, 8 to 30% in Caucasians, and about 50% in Asians. Once exposed to opioids, about a quarter of individuals could go on to develop opioid addiction in their lifespan. And some researchers believe that this polymorphism could serve as a way forward to address the opioid epidemic. Well, what have they done for research? So here's one study that looked at 50 people. They were 29 female, 21 male, and they were fairly young and they were healthy. So they genotyped them. That means they looked to see what was the state of their DNA. And they found that 36 were what, for want of a better term, we'll call the usual or the normal, but 12 were heterozygous for this SNP, and 2 were homozygous. And then what they did with these volunteers, presumably with consent, was they said, well, okay, we're going to see how you respond to pain. So the control was they injected normal saline into the muscle when you clench your teeth. When you write down, that's the masseter muscle right there, that thing that pooches out. And then they would see how did they respond to pain. Okay. Well, what they found was that the people who had either the heterogeneous or homogeneous, they had unrealistic expectations to what they should expect from the control, which shouldn't have caused any pain, and that's the placebo effect. And they had sustained pain with the hypertonic saline they used to create the pain. So the conclusion, and remember, these were healthy people, they weren't addicts, and their conclusion was that yes, this single nucleotide polymorphism does contribute potentially to a personality, as it were, that could easily become addicted. Now, in Turkey, they actually looked at 103 Turks who were addicted to all kinds of drugs, including opioids, and they compared them with 83 healthy controls. And what they found was that the presence of the SNP was 16.1% in the addicted group versus 8.4% in the control group. And there was no correlation with other psychiatric conditions. So their conclusion in this particular study was that, yes, these people are more prone to addiction. And I found this study, which I thought was really interesting because it had nothing particularly to do specifically with opioid use disorder. But these researchers looked at children with disruptive mood disorder or disruptive mood regulation. So they had 85 mother-child pairs in the clinical group and 65 as the controls. And anyway, what they found was, and you can see the distance, again, I don't read slides because everybody here can read, but you can see right at the bottom that the mothers, there were 22% were heterozygous for the SNP and 3% homozygous, and roughly the same in the children. Okay, so what did that mean? Well, when they looked at social withdrawal and conduct issues, they actually found a statistically significant difference between the mothers and the children with the single nucleotide polymorphism, the A118 G. I guess I left the G off of there. Okay, so some takeaways. This gene codes for the mu-opioid receptor. A certain percent of each ethnicity has this SNP. The people with this SNP are likely more prone to opioid addiction. They will have a variable response to endogenous opioids and dopamine and are more prone to mood disorders. The people with this SNP also have a lot of cognitive emotional influence problems that, in the context of what they expect to happen, potentially lead to what's known as the placebo effect. Well, then you have to ask yourself, well, okay, if they're getting, like, say, I don't know if you remember in the movie The Birdcage, where Agador Spartacus was giving Albert the Pirin tablets, and Armand was very angry with him and said, "What are you giving him, drugs?" And Agador said, "Well, it's just aspirin where I've taken off the AS." So they look like Pirin tablets. They were aspirin. People with the SNP might not respond to treatment as well as people without it. And it's a big area for research. Okay, so we're going to go on now to the Kappa. Kappa agonists like pentazocine, Talwin, are analgesic, and they produce meiosis and dysphoria and hallucinations and dissociation. And to be honest with you, we tried them years ago. They're not very useful, certainly weren't useful in anesthesia. Because basically when we tried them, the people would go off the deep end. And this was us giving them IV, so it was immediate. Now, the delta receptor is interesting. They have a very weak analgesic effect when they're stimulated. And for these drugs, for any of the drugs that are in the delta classification to be effective, they need to correct this, I guess you would call it a deficiency, a clinical deficiency. But they are widely distributed and they can also participate in the control of pain. One thing to understand, they all look the same. They've all got this kind of weird, it's called a 7 helical structure. And all of the opioid receptors look essentially the same. So the thing is that they all participate to some extent in pain control and in mood control. Okay, now, buprenorphine, which is kind of the odd man out, which I'm sure you're all familiar with since you're probably all using it. There is a ceiling on respiratory depression and euphoria. And as you can see in this graphic here, partial agonist, antagonist in delta and kappa, and an agonist in the NOP. But keep in mind that people can, and you've probably had this happen, where people become addicted to it, and you have to watch out for respiratory depression. But the thing that's interesting about it, and I think one of the things is that buprenorphine limits another actor in this whole scenario, which is called beta-arrestin. And beta-arrestin is also a signaler for abuse liability. Okay, so that's one thing to think about. That, again, this is not something that's going to have an immediate effect today, but someday down the road, I predict that there will be beta-arrestin modulators that will reduce the abuse potential of opioids. Also, you may not know this, but it's also a local anesthetic because it inhibits the sodium channel, just like all other local anesthetics. Okay. Here's just a graphic of methadone binding in the mu receptor, kind of like what we saw with fentanyl. So methadone also is a beta-arrestin biased mu opioid receptor agonist. And that's probably partially responsible for its lower abuse potential. And it stimulates some other, like the NMDA, N-methyl D-aspartate receptor. It's an antagonist. So again, as we go through, I've only got a few more minutes. As we go through this, there's no way you're going to remember all of this from this presentation. But what I'm trying to get at is this is a really complicated setup. Now, here's something. You're all familiar with nasal naloxone. Well, this is that. Somebody actually did a study to show how quickly it works and how quickly it occupies the brain. So I don't know, you probably can't see my cursor as a pointer, but if you look at the top row and you look at the second image, that's between 0 and 60 minutes, where it has 4 milligrams has been given nasally. And then if you look at the image right below, that's how much of the brain it's occupying. So I think this gives you some anatomical evidence of why the stuff works so quickly. By the way, naloxone shows almost no activity in the absence of opioids. So people can give repeated doses to someone who is overdosed with pretty much without fear, especially until the paramedics can arrive. Okay, cocaine. Well, cocaine is not a narcotic chemically. It's a local anesthetic, and it doesn't bind to the opiate receptors. It binds to sigma receptors and has an impact on dopamine receptors. The problem with cocaine is because it is a local anesthetic, it can inhibit the action potential in the heart. And actually, I was on duty one day when we had a cocaine addict who was snorting cocaine the night before his surgery. I was not in the case. He failed to go under the general anesthetic for a big operation. He was actually having a kidney transplant. And they gave him repeated doses of thiopental, which was the only drug we had back in those days. We didn't have propofol. And he had a cardiac arrest and died on the table, probably due to the cocaine. All right, tolerance. Well, as you all know, tolerance it takes a higher dose to achieve the same effect. The mechanism is quite complicated and it's not completely understood. And it's a lot of different things, which as you can see here is multifactorial. But as I'm sure you all know, the tolerance to respiratory depression is lower than the tolerance to analgesia and euphoria. And that's especially dangerous with drugs that have been cut with fentanyl, whether they've added carfentanil or not, or people that go back to using after a period of abstinence. Now, I will tell you, we had a saying that there is no tolerance to the respiratory depression of fentanyl, period. End of discussion. And if fentanyl is worse, carfentanil is off the charts. By the way, carfentanil is not used anywhere in humans except as a study drug and then under very controlled conditions. Okay, so where is the future? Well, the future lies with pharmacogenetics, pharmacogenomics, and molecular pharmacology. And the first one is the single gene mutation. The second is on multiple mutations, and molecular pharmacology is just like what it sounds, looking at the molecular actions of drugs and other therapies. Okay, so what is being looked at right now? Well, if you look at the third paragraph, this is the complicated story of the research into trying to find a drug that will relieve pain, that won't be addicting, and won't cause the person to stop breathing. And then on top of that, in the final paragraph, they're looking at even more things. So for me to pretend that I could tell you all about this would be improbable, but suffice it to say, there's a lot of research. And by the way, there is a prioritization from our government on the research. Now, here's one example. Some researchers looked at the nociceptin opioid peptide receptor. And this receptor, again, has no affinity for the morphine-like drugs, period. And so they came up with this drug, which is called sabranipodol, and they've actually done a study. Now, sabranipodol has some mu receptor activity, so it's not a pure NOP receptor agonist. But in one study, it was shown to have less abuse potential, and they didn't give a dose sufficient to induce respiratory depression, so they didn't look at that. And that's it. As my final words on this are, since the slideshow will be available, and it's really impossible to do this in 36 minutes, what the main takeaway I want you to get from this is to think about the people that you see, that there may be an underlying genetic component to their addiction, which makes it more difficult for you to treat them and easier for them to be addicted. That's one thing. And secondly, there is a lot of research going on into trying to find something that will solve the problem beyond the kinds of things that you folk are doing. So thank you for listening.
Awesome. Thank you so much, Dr. Desmarteau. This was super helpful, I think, for all of us, and you have a wealth of knowledge, so thank you for sharing that. I think at this point, we'll turn it over to a discussion. Since this is a community of practice, we will encourage just opening up the floor and you all can chime in. And maybe to get that rolling, if anyone has questions, you can ask them now. That would be great.
Well, if nobody has a question, I have one. Does anyone, or is anyone in that does this work doing testing, which involves using PCR for that single nucleotide polymorphism? Is anyone aware of anyone in the area doing testing on that? I mean, not in research per se, but clinically.
I'm not aware of anyone doing any research or work with that.
Okay.
John, thank you for that presentation. I just have a question. So I'm on the community side. So what does this mean for community, and what does it mean for patients, and what does it mean for providers talking to their patients about this? How do we synthesize this? And I know, like you said, it's a lot of information, but how do we sort of synthesize this from provider to community to patient?
Yeah, from the patient standpoint, I think, let me think about this for a sec. I think to synthesize it, well, first of all, if I was doing addictionology, I would definitely not tell a patient that you might have a genetic component, because without testing them, that would be, I think, the wrong thing to do, because that kind of, in a way, leaves off the other factors. Because remember, the SNP may be a predisposition, but it's not the only factor. So that's one thing. I would keep that in the back of my mind. And if I could find a lab somewhere, I might send them off for a test to see, because then it might help me understand why the treatment may not be so effective. And then I might, at that point, breach the subject with the patient, that we're really going to have to work a lot harder, you know, in the work that you do that has nothing to do with something that is immutable. You can't change that. Okay, that's one thing. I think another thing that I would do is, in terms of the people that you deal with, is to emphasize to them that if they're ever in a situation with a friend and that friend has OD'd, and they give them naloxone intranasally up the schnoz, don't be afraid to repeat it. That's a practical point, because you cannot hurt them, right? If they have stopped breathing or are breathing so infrequently that they're on the verge, do not be afraid. So that's another thing, because of the way naloxone, Narcan, works. That's another thing. I think another thing I would do is to talk to a patient who is a multi-drug user, both say, let's say cocaine plus heroin, and maybe describe to them that we are beginning to understand the relationship of how one drug affects the other, and that they are multipliers in their problem with addiction. And that it's really important for them to, well, if they're going to use, try and get off of at least one of the two drugs, because there is an impact between one to the other. And then you'll have a better chance of of the work you do of dealing with the one. Getting back to the also the person who is gladly abstinent in one of your programs, you need to outline the dangers of starting to use again, because whatever tolerance they did build up, depending on how long they've been abstinent, could be completely gone. And so they could OD much, and I'm sure you're doing these things, but in terms of your thinking, you see what, okay, let me put it this way. When I was still practicing anesthesia, to me, giving a general anesthetic is immediate pharmacology, immediate physiology, and immediate pathology. Because when you give drugs IV, you see you give intranasal naloxone. I'll ask you this, Ken, how long does it take? How long would you've probably given it. How long does it take to work? I'm not trying to pimp you out here to use
Yeah, that's not a fair question for me. You may want to ask another provider on the
call.
Well,
you expect it to work in minutes, right?
Right, exactly, right.
Okay.
It's supposed
Well,
to be.
when I gave naloxone to somebody that had gotten a little too much narcotic in the OR, I expected to work in seconds. Okay. So the thing is that when I did anesthesia, I was very aware, we use muscle relaxants that require reversal agents, and those things are all receptor antagonists, et cetera, et cetera, et cetera. So people that do anesthesia are very aware. And after a while, it becomes ingrained. You start thinking about, well, actually, what am I doing here? How is all of this working? And then the last point I think I would make to the people doing this work, and this is something Henry and I have talked about. Let's say you have a patient that you're treating, and that patient needs surgery. I would have a discussion with my patient, if that were my patient, about what can you do to either eliminate or minimize the use of narcotics after the surgery. And if you don't mind, I'll give you some suggestions. I had hand surgery not too long ago, and it's fairly painful afterwards. It was in the palm. I have Dupuytren's, so they had big incisions in the palm here. You can't see them now, but they're there. And before the operation, they gave me some intravenous Toradol, which is an NSAID, and some intravenous acetaminophen, intravenous Tylenol. And my surgeon gave me, I think, was it 4 or 5 tablets of Dilaudid, because it's the only one I can take, after the surgery, in case I had pain. The only thing I took for pain afterwards was Tylenol, plain Tylenol. So that's another thing that I think providers can do, is to, when their patients are going to go have surgery, talk to them about coping mechanisms with the pain afterwards. Now, here's a little thing that a lot of doctors don't even know. And I'll throw this out as a pearl. Acetaminophen, Tylenol, and ibuprofen are completely different drugs. And you can take them together. Or you can alternate them. Some of you can, you look quizzical there. They are completely different drugs. And they have a reinforcing effect one upon the other. So you can tell people that are going to have surgery, assuming that the NSAID, the ibuprofen, is not that they can do them either together every 4 to 6 hours or alternate every 2 hours. And that could potentially eliminate them having any opioids. And one other thing that I just remembered is if somebody's going to have really major surgery and they are concerned that they have been getting either methadone or buprenorphine for their addiction treatment, and they're worried, well, geez, whoever is their provider, I don't want to be I'm having like a really big operation here. I don't want to be in pain. You can assure them that there are rescue medications that we use. And unfortunately, one of the best rescue medications is fentanyl because of the way it binds to the mu receptor. Henry, did I answer the question?
I think so. I think that was great. Yeah, it's awesome.
One question.
Anesthesiologists aren't dummies. We do know a few things, not much. Okay, sorry.
Hi, this is Samantha Hilton, and I just had a question. I think it would be absolutely lovely if there were, more opportunities for genetic testing. But for those individuals who do have, the genetic component for the SNP, what are the recommendations? I mean, is it like largely pharmacological, or is it, therapeutic? I imagine it's a combination of both. But, for those who are a bit more treatment resistant because of that, genetic component, but what would be the recommendation for those individuals?
Okay, well, that's something that actually I will pursue in terms of doing some more research. But from what I can glean from what I've seen is that you are correct. The buprenorphine may not be as effective, or you may have to modify the dose, or methadone. But you probably will also, because remember, these things are not absolute. This is the nurture and nature discussion that often comes in here. It's not an absolute thing. They're more prone to addiction and somewhat more resistant. So I would think that you might have to do more intensive psychological therapy. And I don't know how, in the absence of the testing, I think you might conclude that a patient that is not responding the way you anticipated might have the SNP, but without testing them, there's no way they're going to know.
Thank you.
There's Samantha, there's no magic drug that's going to overcome the SNP, as far as I know at this point. Maybe down the road someday there will be, but not at the moment.
Hello?
Hello?
Hello, this is Claudia. Hi, are you there?
Yep.
Okay, great. I've been a nurse for 39 years. I've had lots of horrific experiences. The most horrific being a right hip replacement in October of 2021, and then a right hip spontaneous dislocation of the same replaced hip in February of 2022. Oh. And I just want to say, as a healthcare provider for all those years, I could not have been treated more unprofessionally. And I basically bled into my hip for 24 hours that I required 2 units of blood. And they chased my sodium for 5 days, and they sent me home on iron and salt tablets. So I just want to just give a shout out to the people there that know more than the average bear. And I couldn't get anything more than taking Tylenol and ibuprofen together, and which was not really very helpful, and was not really very helpful for my rehab. and I'm still struggling with my rehab today as of June 28th, 2022. So the opioid addiction situation and trying to get pain med when I dislocated my hip in the ER required them getting 4 ampules of 2 milligrams of morphine twice. They gave me 8 and then 8 again, and I was still extremely lucid after 150 mics of intranasal fentanyl plus 40 milligrams of ketamine. And I was doing the math with the guys on the ambulance because they had 2 different doses of ketamine on the ambulance. And I was like, guys, this is a medication error waiting to happen because this is how babies bled out and died in the NICU. And they're looking at me going, what is she talking about? And the one guy had the sense to say, yeah, that actually happened. And the 150 mics of fentanyl had 0 effect on her. And they were all thinking I was some drug-seeking toad. And it's like scarred me. You know, I'm like very, very sad and disgusted with my fellow healthcare professionals with how poorly I was treated with regards to my level of pain with an actively dislocated hip. And to your point about respiratory situation, when they finally knocked me out with IV fentanyl, when they finally yanked on my ankle and popped my hip back in, I stopped breathing. They had to give me Narcan and bag me, and they sent me home with no pain medication. Well, unforgivable in my book.
Yeah, well, I think that's when that's an example of what I would call uncontrolled polypharmacy. And you know, there's one thing about having an operation, being under a general anesthetic in the operating room where it is a controlled situation, and you know, the people doing the anesthetic are very aware of the drugs that they are giving, the dosages. And remember, there does come a point in every general anesthetic where we have to wake you up. It's not a, yeah. There does come a point, whether it's in the OR or the ICU, at some point you have. So I just, in case anybody else has a question before we have to end here, I just want to say that that's an example of, if you think about it, that's an example of recruitment of too many receptors. Too many receptors. I mean, if we're going to relate it back to this talk, your ketamine is a weird animal, which is on a whole other spectrum. And they're giving you, you know, intranasal fentanyl, and then they give you IV fentanyl, and you know, obviously the Tylenol and the ibuprofen don't have respiratory depressive effect.
Well, no, they had given me.
Yeah. So yeah. So I think that's an example where I call that uncontrolled polypharmacy. That's what I call it. So are there any other questions before we have to wrap it up here? I do have one other question that maybe someone could answer. One of the things I discovered in doing the reading for this and the research for this, because obviously I'm not a researcher per se, I was a clinician almost my entire life. Is anyone using naltrexone for alcohol and gambling addiction? Because apparently some people are with success. You know, we tend to think only of opioids, but there are other addictions, gambling and alcohol being two that I found research where people are using naltrexone, which is a long-acting opioid antagonist. No, guess I'll take that as a no. Something to think about if you have people that, oh, I got yes, the team here uses it. From, that was in the chat. Let's see, I haven't been following the chat. Let's see. Yeah. Yes, we use it for alcohol. Also add on for stimulants. Somebody in Utah. Okay. Somebody asked about sending out the PowerPoint and the recording, and Henry said he would. And I think that's it.
Awesome.
Well, Henry, was this useful?
This was incredibly useful. I think it was really cool to get into the weeds on some of this stuff and really into the details. So thank you for that and for taking the time to put together that helpful presentation. And
John, you are getting a lot of thank yous in the chat that this was very helpful. So people are responding in the chat that it was very helpful. So that is good as well. Just wanted to point that out.
Appreciate the opportunity. Also, my final words will be that a lot of people don't realize that anesthesiologists are physicians. But as the boss, when I did my residency, used to say, we are the only people for whom a chronic disease is defined as any adverse process that has been going on for 3 minutes. Everybody else, a chronic disease is something that's been going on for 3 to 6 months. So.
Very interesting. Well, Dr. Desmarteau, thank you again. And just to note, I will be sending out an email with this recording information. So we recorded this, so you'll get a link for that with a password to access the recording. Also, if you'd like to claim CME and CEU credits, there will be a link with that. I'm also sharing some resources that Dr. Desmarteau has graciously supplied for both this COP and also the past sessions COP. That was session 2. Some good resources on that too. So everyone should be getting that email within 24 hours. As always, feel free to contact me if you have any issues with that. The only last thing is that we do have an evaluation survey that will also be sent out in that email. It's really helpful if you all can take it. It's about 5 minutes to complete the survey. And it lets us know how we can improve these meetings, and also gives you all an opportunity to tell us what you'd like to learn more about. So I encourage you all to take that survey.
And you're going to let people download the PowerPoint, correct?
Yes, I can provide the PowerPoint for you all. So that'll be in the email as well.
Okay.
Awesome. Well, thank you again so much, everyone, for joining. Thank you, Dr. Desmarteau, for your time. This was great. So thank you, everyone.
Okay. Bye-bye. Happy 4th, everyone.
Thanks, everyone.